Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Welcome to special conference coverage from the 2026 Elevate-Derm RAPIDS Conference. I'm Victoria Garcia Albea. I'm a dermatology nurse practitioner. I work outside of Boston, Massachusetts, and I am joined by Dr. Jason Hawks from Oregon. He just gave us a whole bunch of lectures on a variety of exciting derm topics. Let's get started with the really nerdy stuff. Can you tell us a little bit about resident memory T cells?
Yeah, the nerdy stuff is my favorite stuff. The resident memory T cells are different from the T cells we talk about in, say, psoriasis, atopic dermatitis. These are the long-acting resident cells. So they stay in tissues for a long time. They can be stimulated many years after, say, a flare. They can drive disease locally. So even if we shut off the immune response, some of these cells may stay in the tissue for many years. And it explains a lot of things we see. Why do psoriasis patients keep getting plaques on their knees and their elbows? Why do we get fixed drug reactions that just happen at the same spots? So there are cells there that are primed to do that reaction at those locations. So getting closer to remission or long-term disease control, we probably need to hit some of those long-acting cells in the tissues to try to shut off disease outside of where it starts in the lymph nodes.
And we don't know why those memory T cells are there to begin with.
Well, we have explanation as to why they should be there potentially. So your skin is your first level of defense. So you want to have T cells there that are primed to act against, attacks on the body. So if we go way back to where we weren't in nice clothes and houses and living out in the jungles and those types of environments, then the skin really was critical to prevention of infection. So we know that things like psoriasis increase your proteins like antimicrobial peptides, probably conferred some protection. But we want your skin to be that first attack or defense against a pathogen. Good reason why those cells might want to be there. We know that most of these diseases are sort of a transmission of something that was protective that became pathologic, right? There was probably some benefit to having high type 2 inflammation in atopic dermatitis and high type 3 inflammation in psoriasis. It's just that as those persisted and some of those selection factors went away, we're left with the disease.
Excellent. Thank you. I think it's really exciting that we're moving away from injectables and we're, getting all these new medications that are in the oral space. Icotrokinra is new. I would hope I can ask you to talk a little bit about that and, what you might find exciting about it. And then also, do you find that your patients lean more towards preferring a pill? Obviously, everybody's different, but on average, do you think patients are maybe more excited to take a pill rather than an injection?
Yeah, this is a critical topic, and it's one that's not surprisingly really polarizing. You get the hardcore biologic people, and then you get those that don't really want to do biologics. Here, I probably lump together because I don't think it's one that's right or better than the other. They both have advantages. So biologics, big molecules, they're expensive. They have to be a shot or IV. You can't put it in an oral form. It only hits things extracellular. You can't get inside cells. So if you're trying to target a intracellular signaling pathway, biologics don't work. So they have their own limitations. What they're good at, consistent drug levels. They're, less frequent. You can do it, we know many medications every 3 months, for example, or every couple of months. This gives you a chance to kind of get very consistent drug levels, ease of administration. But you still have to deal with the injection. You still have the refrigeration component. So they're expensive. So I think the opposite side of that is to have an oral therapy where you have these small peptides. It's totally different. It's not a small molecule. Small molecules are small, simple, but they go through tissues very easily. They go through the liver. They have drug-drug interactions, and they don't stay on a target very well. So where the biologics are snipers, they hit a target really well. Small molecules hit it just a little bit. That's why we tend to see them not being as effective unless they're broad acting like the JAK inhibitors. So icotrokinra is a small peptide. It's about 10 times bigger than a small molecule. So it has more surface area, binds to the target more like a biologic than a small molecule. So it stays on target better. You can suppress it better, but it's small enough it still gets inside cells. And so this allows us to kind of get the benefits of both worlds. You can take an oral pill, but get kind of like biologic efficacy. And in fact, icotrokinra or icotide has a head-to-head against ustekinumab. And I think there's a good chance it actually probably wins. So I think we're now seeing this new class as having higher efficacy, but it has the safety profile of some of the biologics. So we're not seeing drug-drug interactions. It doesn't get metabolized by the liver, but it does really good job at blocking the IL-20. So I think this is going to open up the conversation that we weren't having before, which is that do you want a biologic or a small molecule? We were saying with small molecules, not very effective or very effective, a lot of side effects. But now you kind of close that gap. You say, well, now there's a really effective pill you could choose if you really don't want to do an injection. So I think it puts the patient back in the driver's seat, like that shared decision making. And when you do ask patients, there are a lot of patients who actually prefer a pill, and some prefer a shot. But I don't think that's our place to necessarily push one or the other.
Right.
It's really trying to fit like what they really want to do. A lot of patients will say, I already take my blood pressure medication or my cholesterol medication. It's easy to throw in a once a day pill. So I think we just want to try to get patients to take the thing that they're going to do consistently because we want to help them get disease control. So I personally don't, it doesn't matter to me. I always tell patients,
Yeah.
I don't care which way you go. Just let's pick the thing that makes the most sense. And obviously what you can get covered. We don't want it to be cost prohibitive. That access is always important.
And the nice thing about ICO is, as you mentioned in one of your lectures, that you can dissolve it in water.
You can. Yep. You can dissolve it in 4 ounces of water. Wait till it gets uncloudy and you don't see any particles. You can add some more water, take it. So that's good for the adolescent population, which another unique part of Icotide is that you basically can give it to 12 years and up.
And-
But that group can sometimes not take pills.
Right. And I'm sure they would prefer a pill over a shot, though. Do you have any concerns about ICO? Any special monitoring that we need to do for our patients?
Really, no. I think it has the familiarity of the IL-23 class.
Mhm.
So, we don't have drug-drug interactions. It doesn't get metabolized by the liver. What's absorbed gets removed by the kidneys. What's not absorbed goes out through the feces. So no drug-drug interactions. There in the label, there's no requirements for tuberculosis testing.
Great.
It says sort of, consider evaluating your patient.
Are you going to do that, or have you been?
No, especially because we have new guidance with, the NPF and AAD talking about, not really needing tuberculosis testing in IL-17 and 23. Unfortunately, the FDA, I think, carries through themes as opposed to really looking at the evidence. There's really no evidence that the IL-23 and 17 blockade increase your risk of tuberculosis. So
So do you do like an initial baseline quantiferon gold for your patients you're starting on a biologic and then not again unless there's a risk factor?
yeah, this comes up a lot. It's going to depend on areas. There are insurance providers and regions that are requiring it.
Mm.
But I think the short answer is that in the absence of a requirement, you don't need to do it if you feel that that patient doesn't have risk factors. I mean, in Oregon, for example, do we see tuberculosis? Not really,
Yeah. Same
right?
with Massachusetts.
If somebody were traveling to a high risk area, and they might want to have it because if it is required later, then it's not wrong to do it. I think it's the annual rechecking of it that's the problem. But that doesn't have any basis. But to get through the hurdle initially, I think that's enough. If you don't have to do it, then we don't need to do it. Just
Right. It's
making
an
patients
expensive
think
test.
that, oh, maybe there's this risk.
Right. So now that we're getting all these new oral medications, it's kind of funny because the tide has shifted and everybody's getting on GLP-1. So people are less hesitant about injection medicines, right? Take us through how you're actually incorporating GLP-1s into your practice for inflammatory skin disease.
Yeah, this has been years in the making because we've known about the risk with diseases like psoriasis and obesity, but those medications that work for psoriasis don't have an impact on obesity. The VIP trials, the clinical trials that Joe Gelfand and Nehal Mehta and others were involved in, was trying to study, could really good psoriasis control help these comorbidities?
Mhm.
And the answer is sometimes did and it sometimes didn't. But the therapies that did work, it didn't make sense because there were other therapies that had better skin clearance and
Right.
they didn't really come up as having that link. So it showed you there's a complex relationship between the two. I think the hope is if we can get good control of the skin, but we can't hit the comorbidities, what can we do to hit the comorbidities? Because that association is very clear. We know psoriasis patients, for example, have an increased mortality. It's
Yeah.
probably somewhere in that 5 to 7 years. That's significant.
Yeah.
So I think the first trial where we had ixekizumab versus tirzepatide, which we talked about in the lecture, really kind of got at this point. What does adding an obesity targeted drug do to psoriasis control? And not surprising, it helped with psoriasis and those patients felt better.
So, are you prescribing GLP-1s for your patients with inflammatory skin disease? Let's specifically talk about psoriasis for a minute.
Yeah, well, sometimes you don't have to because those patients are already on therapy, right?
True.
So even when we're talking to patients, for example, in the clinical trials, they'll come in like, "Can I start this?" Like, I met with my provider or I went online,
Mm-hmm.
and so a lot of patients are already looking for those therapies, but we're certainly having the conversation. I don't think it's realistic that most of our specialty will prescribe them, but I think you can learn about them. Even if you don't prescribe them, you can encourage patients to go on them. But personally, I feel comfortable that, prescribing that to patients. You do have to learn some of the basics and some of the practical points. You need to have those conversations. What's interesting, the clinical trials, they also had meetings with a dietitian. So, they were talking about, we know about this muscle wasting that can
Yeah.
happen. And, so talking to them about, increasing protein intake and, making sure that they have an exercise routine, building muscle strength.
Mhm.
So I think it's fine if people in our specialty do that. It doesn't necessarily have to be our specialty either. Just in the same way of, say, psoriasis control patients that have high risk for kidney dysfunction, chronic kidney disease, or diabetes, or cholesterol. Are you managing those? Not necessarily. But if nobody's checking that in a patient, then we probably should. So I think we just want to encourage patients to look at that as an option for them if it's appropriate, have the conversation. I think if there are many derm providers that are using it, I personally would feel comfortable if a patient's like, I don't have a primary care and
Yeah.
obviously I have all these risk factors, then I think it's good. I don't think it's any harder than medications like cyclosporin or methotrexate or
Mhm.
acitretin, for example. These are medications that take a lot of extra work and monitoring. I think
Counseling.
these are pretty straightforward medications. They can be expensive for patients, so getting access is important.
If you have the opportunity, if it's, in your hospital network, are you referring these patients to like a weight management for more of that whole, patient care, talking about diet and exercise and stuff, or are you just managing it?
I mean, the problem with the academic centers in general is that they're just overburdened. Like,
Yeah.
you can't, like dermatology, like my partner and I are both on faculty at OHSU, but there's like a 6 to 8 month wait for dermatology. So, I think in the community, we're privately owned, just he and I own the practice, but we can get patients in same week
Wow.
for some of these more severe patients. So it's not realistic to say we're going to send them to these key centers. Well, what if those are 3 hours away? That's
True.
not reasonable either.
True.
I think teledermatology, for example, can maybe fill in the gap. A
Hmm.
lot of these patients in the trials, for example, did these telemeetings, which I think is
Yeah.
nice. I don't
But
think
that's
it's
still probably a copay every time and all that
sure.
stuff.
Yeah. I mean, I think for the uncomplicated patient that has a couple of things going on, I don't think it's necessary, but there may be people that need more comprehensive management. But I think primary care is pretty well equipped to help. But I think, they're overburdened as well in a
True.
different way. But I think it's just not probably practical. It'd be ideal, but our healthcare system is fragmented and that creates problems.
So, how about our patients with psoriatic disease who are not obese? Are they candidates for GLP-1s? Because we learned from your talk that in psoriatic plaques, there is GLP-1 expressed in those lesions.
Yeah, so the expression of those receptors, I think they're not necessarily tied to the pathogenesis. It doesn't mean that that's like a key signal driving psoriasis, but it tells you that in the immunology with psoriasis, there must be some link with obesity. I think this is driven home by the story that these pediatric patients, they often get obesity first, and it's well over 90%. It was a study a while back by Amy Paller, pediatric dermatologist, where these patients who had family histories of psoriasis, they got obese first. And so we know that there's some interplay between the psoriasis pathogenesis and obesity, but we don't really understand when it turns for
Mm,
patients. And same with psoriatic arthritis. These patients you're talking about, why is it that some patients get psoriasis and never get psoriatic arthritis? Why do some patients get psoriasis and psoriatic arthritis at the same time? We see that's not always a delay. And some patients get psoriatic arthritis first and then plaque psoriasis. So it starts to highlight the complex relationship between the immune response, probably some genetic factors. But I think in a patient who had psoriatic arthritis, in the absence of clear findings that were metabolic syndrome or hypertension or diabetes or obesity, there's probably not a lot of rationale for putting them on therapy in the absence of those risk factors, or at least characteristics. But it would be something that we want to talk to them about, that you have a risk for obesity and some of these other things over time. So we're going to keep monitoring you or make sure somebody is monitoring you. So if those things do start to develop, we have a low threshold to kind of pull a trigger.
thank you. All right, just to wrap it up, what are your thoughts on treatment issues that are associated with biologics with these very extended half-lives?
Yeah, it's a great innovation because we know that what appeals to patients is fewer pills, fewer shots.
Right.
So that value prop to patients is real. The idea that you could potentially inject a medication once a year and keep and maintain your disease control, like that would be a
That
game
sounds
changer.
perfect,
Yeah,
right?
that'd
Yeah.
be a lot of patients say I go in and get my once a year psoriasis
It's
shot.
like your flu shot.
Yeah, exactly. And that would have a big appeal to a lot of patients. The issues that we have to think about are what happens if a patient develops a side effect early on. You can't sort of suck the medication out,
Right.
right? So I think this pathway that we're starting with, IL-23, is actually, very safe at high doses. We know that. The knockout study, for example, gave up to 4 times what risankizumab was. So we know that there were no new safety signals. Like that was important for underscoring the safety of the pathways. But you move not too far away with IL-17A and F. There's definitely more adverse events that happen. They're not serious, but they can be problematic. So, oral candidiasis or vulvovaginal candidiasis, esophageal candidiasis, are these going to occur at higher rates when you extend the half life? Because effectively, what these drugs are doing when you inject them, it's preventing them from being metabolized. So they stay around for a long period of time, and that extends the half life. And they also have some modifications that help them not get broken down by the immune system. So that'll be one question, is if you do get a side effect, does it persist for a long time? Is it harder to manage? We don't know until we do those trials, which are ongoing now. The other issue we've had with some of the medications where you space them out too far, patients will notice that in between injections, they're kind of getting a rebound. That was probably the most prominent when we were taking care of patients with ustekinumab.
Yeah.
And so we had to go from that 12-week to the 8-week
Mhm.
dosing. So longer isn't always better. You have to have, if you're going to extend the length, you've got to do a better job at hitting the target.
Mhm.
So when we talked about Aruca, where they had patterned their medication, their 001 compound after risankizumab, but it's a higher dose. So it's a higher dose and it's extended. So that'll be kind of the question mark on some of those little nuances. And patients don't necessarily feel better. The flip side, so if I can get a shot once a year, great.
Yeah.
But there are some patients like, I don't want a drug that's acting my body all the time for these long periods of time. They're effectively doing that if we do it at shorter intervals, like once a month or every 3 months. They're still getting consistent levels, but
They feel more of a control.
yeah,
They can choose not to do it or skip it if
exactly.
they have a fever or whatever.
So psychologically, it doesn't feel that comfortable, like the idea of fast on, fast off.
Mhm.
So, medications like remibrutinib for CSU or even the JAK inhibitors, you can take them, they're
Yeah.
quick on, and if you have to stop them, you have a surgery coming up, you can do that. So, people have a hard time predicting what's going to happen 6 months or a year out. So there may be situations where they don't want to be on those therapies for whatever reason. And so it's going to find its place, but there'll be some unique challenges that we'll have to think about. And one practical issue that we see in the clinical trials is that basically there's a standard language in the clinical trials that say that if you've been on an investigational drug previously, it either needs to be 30-day washout or 5 half-lives.
Right.
But some of these medications have 75-day half-lives. So, 5 times 75, they can't be in a clinical trial for that whole period of
Yeah.
time. So
And th
it's a practical problem.
and that would be true, how we usually say that for live vaccines and things like that. So it would also be really difficult to plan your life.
Exactly. So they'll have unique challenges, but this idea of getting closer and closer to better disease control with fewer administration, I think overall that appeals to people.
Excellent. Any closing remarks?
No, just that this is a fun time to be involved in dermatology that I think, whether, you're an APP or an MD or even a patient, like the science is even more important. You can't practice now without really trying to know some of the science because you're making clinical decisions about drug A versus B versus C, but you're taking in all the information in the clinic and you have to be able to tease through that. So I think this having competition, more options, more innovation should be forcing us to learn the fundamental basic science. You don't have to do the science, you don't have to do the
Mm.
research, but you have to be familiar enough with it to have the conversations, explain it to patients, tease through some of the data, some of the things that are being published, know what's real, what's not real. So it's a fun time, it's a challenging time, but I think we have to keep upping our game as the medications get upped as well.
That's why we have to keep having you back to
Okay.
nerd out and keep us updated on all the nuances, the differences between all the medicines, all the different pathways. I wish there was a plug, like in the Matrix, we could just download it into our brains. So when's
Yeah.
that going to be here?
I don't know. That's the Johnny Mnemonic, right? The
Yeah.
movie. So one day, but in the meantime, we learn from each other, and that's what makes specialty fun.
Great. Well, thank you for joining us, and we'll see you next time.
Thanks for having me.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.